Good afternoon, and welcome to the Consensus or Controversy, documenting and discussing investigators' approaches to the management of advanced gastroesophageal cancers. I'm your moderator, Dr. Yelena Y Janjigian, and we have big shoes to fill. In fact, Neil Love is, of course, the master at this, but we will make do. We have excellent faculty today, and today I'm joined by my colleagues and friends, Dr. Manish Shah, who is a professor of medicine and chief of solid tumor oncology at Weill Cornell Medical School and Medical Center, and of course, Professor Erik van Cutsem, who's professor of medicine at the University of Hospitals of Leuven in Leuven, Belgium. It's such a pleasure to welcome you here, and in preparation for this meeting, Research to Practice conducted a survey of this evening's faculty, so all three of us, plus three additional experts and clinical investigators in the field who provided their perspectives on a number of issues related to the management of gastroesophageal cancers. The select results from this survey will be discussed during the program to generate discussion, and full results will be available for you to review and download and study. So we're going to go through the conflict of interest for the faculty and as they see here. Here, commercial support for today. And so Research to Practice CME Planning Committee and staff, there are no COIs from the Research to Practice to disclose. This program will contain discussion of non-approved uses of agents and regimens. So please refer to the official prescribing information for each product of the approved indications. So here we have the title slide for our program, and again, it's really to focus on the consensus or controversies to see how our experts are thinking and get your opinions on the real data. And so we will begin our agenda, of course, with Dr. van Cutsem, covering her two targeted approaches in advanced gastroesophageal cancer. So Erik, please go ahead.
Thank you so much, and thank you to Neil Love and his team, and thank you, Yelena, for this introduction. And indeed, we have seen a lot of progress in targeting HER2 positive G-junction or gastric adenocarcinomas, going from the single epitope monoclonal antibodies trastuzumab to antibody-drug conjugate to bispecific antibodies, and in gastric cancer, to a lesser extent, to the small molecules. And I will discuss in this short presentation some new data on the new drugs that are available and new strategies. The first important progress after the data of trastuzumab were the data of KEYNOTE-811, first-line treatment, chemo plus trastuzumab versus chemo trastuzumab plus pembrolizumab, which Yelena and others reported several years ago, showing a clear progression-free survival benefit, a clear survival benefit in patients with HER2-positive G-junction or gastric adenocarcinomas, and especially also patients with a PDL-positive tumor. The subgroup analysis in this study in the PDL-positive tumor showed that there was the benefit, especially in this group there. At this meeting, these are the data from the abstract. The data will be presented later at this meeting. The long-term follow-up, 6-year medium follow-up, and as you can see, and as you can read already in the abstract, and you will see the data tomorrow being presented, 6-year medium follow-up confirms the clear benefit, consistent benefit of the addition of pembrolizumab to trastuzumab and a chemo doublet. Last night, there was a publication in the New England Journal of Medicine on this drug, zanidatamab. The data were presented at ASCO GI for the first time. There will be updates here at this meeting. Zanidatamab is a HER2-directed bispecific antibody that binds to two different epitopes on the HER2 receptor, ECD2 and ECD4, which are relevant epitopes. And therefore, this is a new bispecific antibody that has been studied in the Horizon GA01 study published last night in the New England, as I said already, which was a study in more than 900 patients, HER2 positive, regardless of PDL marker. There was a randomization, trastuzumab chemo, chemo plus zanidatamab, or chemo plus zanidatamab, and the PD antibody teslizumab. This was a 3-arm trial with a comparison A versus B and A versus C, with 2 primary endpoints, PFS and overall survival. And this is the primary endpoint, the PFS, according to the independent committee. And as you can see, there was a clear progression-free survival benefit in favor of zanidatamab plus tislelizumab plus chemo versus trastuzumab chemo in this. And what is for sure will be a discussion point is what about PDL-positive tumors? And as you can see here in this study, there were PDL-negative. Here the TAP score was used, PDL-negative tumors and PDL-positive tumors. And if you look at the forest plots on the bottom, in green, for the zanidatamab-tisli chemo combination, you can see that there was a benefit in as well the PDL-negative as the PDL-positive tumors, with a TAP cutoff of 1% in this study. The overall survival was clearly better, longer for the combination zanidatamab-tislelizumab, with median survivals of now clear over 2 years, 26 months, 26.4 months versus 19 months in this study. And also the overall, the survival benefit was there, regardless, as if you look at the bottom of the forest plots, regardless of the PDL status, TAP negative and TAP positive tumors, there was a benefit in this study. There will be an update on this, and this is taken from the abstract. The data are not yet out. And what it shows is that looking at what this analysis, what this abstract does, it looks further into the benefit, the PFS and OS data of the comparisons zanidatamab-tisli versus trastuzumab in PDL-negative and PDL-positive tumors. And if you read fast through the different numbers, as I mentioned already, and this gives a bit more details, and you can see that more tomorrow and the next days at the meeting, the benefit is there for PFS and OS, regardless of the PDL status. We don't have a good explanation for that, and I'm sure we can discuss that later on. There was a second comparison, zanidatamab versus trastuzumab plus chemo without tislelizumab. There was a trend for an overall survival benefit with a relatively short follow-up. This trend was not yet statistically significant, with a hazard rates of 0.8 and a p-value of 0.056, as you can see. Response rates were not clearly different, but the difference is that the response duration in the tisli zanidatamab arm was clearly longer compared to the zanidatamab without tisli arm, and clearly longer also compared to the trastuzumab chemo arm, if you look at the numbers, 20 months, 14 months, 8 months in the response duration. A challenge will be, of course, in the future, how we can manage adverse events. As is reported in the New England and in the previous presentations, there is more diarrhea. The diarrhea is mainly related to zanidatamab. That's what you can see there on the left part of the slide. There was more diarrhea in patients treated with zanidatamab plus chemo compared to trastuzumab chemo, and also more diarrhea in the arm with tislelizumab, but no clear difference in the arms with and without tislelizumab in this setting. And that leads to, and there is also, again, another presentation at this meeting, and I just took some data from this presentation, not with the goal to read all these numbers, but with the message that we have to learn, we have to understand that, and a couple of clinical keynote messages that are relevant for clinical practices. Diarrhea is most frequent, is most often grade 1 and 2, and tends to occur most often in cycle 1, sometimes in cycle 2, and resolves often in many patients in less than 3 weeks. Diarrhea rarely leads to zanidatamab discontinuation in this setting. And there is a learning curve, and what has been learned is that diarrhea should be managed with prophylactic loperamide and chemotherapy dose modifications if needed. I'm sure there will be soon many other publications coming out on this to guide clinicians how to do that in an optimal way in this setting. In antibody-drug conjugates, trastuzumab deruxtecan has been studied in the DESTINY-Gastric04 study, was presented last year by Kohei Shitara and others. Comparison of TDX versus ramucirumab paclitaxel. Clear benefit if you look at all the different endpoints in this second-line HER2-positive study, in this looking at the different endpoints, whether you look at survival, progression-free survival, response rate, there was always a benefit for trastuzumab deruxtecan over ramucirumab paclitaxel, with some specific toxicities, chemotherapy-related toxicities, and in around 10% of the patients, in the majority it's a grade 1 or 2, interstitial lung disease or pneumonitis as being the most frequent, and as a clinician we have to be aware of this in this setting. There will be additional data being presented at this meeting by Kohei Shitara also on this analysis of the DESTINY-Gastric04 study, looking at quality of life with the message that the findings support patient-reported, that the patient-reported quality of life was maintained through the further treatment. There is a study now ongoing based on the work Yelena did in different arms in first line with trastuzumab deruxtecan in combination. And with that, the study is in PDL-positive patients, TDX plus 5-FU plus pembrolizumab versus standard treatment. And in the PDL-negative patients, it's TDX plus a fluoropyrimidine versus standard of treatment. That study is ongoing in first line, so it's not yet, we don't have yet any data, of course, in this setting. And finally, just to make the picture complete, this is data from a bispecific antibody from China, studied only in Chinese patients. It's a bispecific antibody that was studied in second line, anbenitamab. They reported in the Annals of Oncology very recently that there was a clear benefit. You can see the separation in the survival curve in second line compared to a standard, compared to a control arm in this setting. Of course, these are early data, but it was a randomized, relatively small phase 3 study in China. This has to be confirmed also in Western patients in this setting. So that gives a scope of where we are right now on the different treatments and new agents in gastric cancer for HER2-positive tumors. Thank you very much.
Great summary of the data, very robust data coming out, and the HER2 world is constantly evolving. So I think maybe let's pause for a minute and just discuss what our experts voted on. So the first question was, regulatory and reimbursement issues aside, what first-line treatment would you most likely recommend for a 65-year-old patient who presented with metastatic Claudin 18.2 negative, HER2 positive, microsatellite stable gastric adenocarcinoma with PDL1 score of CPS 0. So, Eric, perhaps I would ask you to kind of walk us through your rationale for choosing FOLFOX trastuzumab. And again, remember, this is regulatory and reimbursement issues aside, because I know Europe things are quite complex. So even if you had access to Zani, you would still use Traz? Is that the case?
No, I think in my answer I took into account regulatory and reimbursement issues. Zanidatamab is not yet approved in this setting. if it was approved, then I would change my. Then I would go for probably Folfox in this setting. Although the trial was with Capox, Folfox, tislelizumab, and zanidatamab, also in the PDL negative patients.
Manish, it's so good to see that we agree as always. But pretend you're Zeph for a second. And tell me, why would you add Tisli? Is the data convincing enough?
Yeah. So, this is great. So, I think 2 points I'd like to make, and thank you for having me here. One is that this study, the Horizon study, was developed before pembrolizumab was approved in the first-line setting, and so. They had 3 arms, and the control arm did not include pembrolizumab. And unfortunately, that's in part why there wasn't any enrollment in the United States. But there was good enrollment in Canada to sort of address the North American population. But I think, so one question is, does tislelizumab add to chemotherapy and zanidatamab in the PD-L1 negative setting? And the data that Eric presented is quite compelling. Tislelizumab adds a lot of benefits: the increased duration of response, the overall survival benefit when compared to trastuzumab and chemotherapy. But what we haven't seen is the comparison of the overall survival of zanidatamab and chemo plus or minus Tisli, arms B and C. That data hasn't yet been reviewed, in part because I think it's like a stepwise analysis. And I guess the other thing is that in your study, Keynote-811, the PD-L1 less than 1 group, there was a suggestion that perhaps the addition of pembrolizumab certainly not better and maybe slightly worse. So we really don't know the benefit.
Yeah, so it's hard to sort of piecemeal this data. So I think we need to keep waiting for additional results. Yeah. Okay, the next patient is also a 65-year-old patient. Again, no constraints for reimbursement. HER2 positive, PD-L1 positive, but low positivity, CPS1. Claudin negative, and as you see here, our experts pretty much unanimously agreed that giving some sort of anti-PD-1 therapy is useful. And once again, Dr. Weinberg, next time we have to have him here so he could, he seems to be the outlier, but we can move on from that. I think what it comes down to is in my opinion, and if you've used zanidatamab, it's not as well tolerated as trastuzumab, but it is more potent. So what it comes down to is the patient sitting in front of you. How are they feeling? How likely are you to be able to get them through Zani? And a combination of 3 drugs, chemotherapy plus anti-PD-1 and anti-HER2. Obviously, with each drug, there'll be more adverse events. So is this a patient who you will tip over and then they'll end up in the hospital? Because Keynote-811 is very well tolerated. So I think perhaps Dr. Weinberg thought that maybe the patient was frail. Okay, next slide. So for a patient with, in combination with anti-PD-1, and if you want to elect Zani chemo, so if you were to choose anti-PD-1 antibody, which anti-PD-1 antibody do you want to be a purist and only go with Tisli, or can you use any anti-PD-1 antibody? And as you see here, the panel is split down the middle, with many of us, use whatever is available on the formulary in our big hospitals, because Manish, myself, and Sam are all practice at big tertiary cancer centers, while some investigators are going by the book. But we all agree that anti-PD-1 therapies are all very similar. So a lot of times we pick it just based on timing of therapy and what's available on the formulary. Eric, any comments about Tisli versus Pembro?
I don't think we can say that that there is a clear difference between these different agents. In this setting, preclinically, there are some differences. And if you look in preclinical comparisons, Tisli may be a bit more active in some models compared to Pembro, but in clinical practice, that has never been shown. And but yeah, we usually stick to the data in the
clinical
trial.
data for anti-PD-1 therapy is, if you went by that, these immune models are just all limited. So patient's immune system is critical. Okay, next slide. So in general, which targeted strategy would you prioritize for a patient with newly diagnosed? Now it's Claudin 18.2 positive. And again, it's an important biomarker. We all should be testing for it. But also HER2 positive patient with gastric and GE junction adenocarcinoma, and a landslide, and we all agree that HER2 is the important target and would be the preferred target. And of course, perhaps in the next few years, we'll see combination strategies that target both HER2 and Claudin simultaneously. Of course, we're all very interested about it, especially with biparatopics and ADCs. But right now, the HER2 target takes the precedent. So no controversy there. That's good. Okay. And I think we have, is that it for the questions? Or do we have one more? One more. All right. Ignore the tramadol. I think that was a typo. I don't have a secret sauce for getting these patients through. Everybody's giving their patients tramadol. No, I think... the zanidatamab, for those of you who've used zani, it's, the diarrhea is a real issue. And I think, we really need to pause and discuss it. But it looks like we could maybe table that for the Q&A session. Loperamide is your friend. Make sure the patient has it in their hand before they're leaving clinic. And a lot of it is, follow up with the patients, making sure the nurse sometimes calls them to make sure that they're actually taking it. Because even in my clinic where my patients are extremely compliant, and the compliance rate for loperamide is not good. Next slide. Okay, so shifting gears a bit about after, what happens if these HER2 patients live for a long time, so that's good. So this is a second-line patient, Claudin negative, HER2 positive, PD-L1 CPS1 with progression on zani, chemo, and Tisli. And what would you give them? And of course, Dr. Van Cutsem reviewed level 1 evidence, randomized study. Trastuzumab deruxtecan is the important. It's important to note that we do encourage rebiopsying to make sure the patient is still HER2 positive, if feasible. Next slide. Okay, and outside of the clinical trial, what are the, in a patient who had progression of disease on FOLFOX, TRAS, Pembro, second-line trastuzumab, would you use off-label zani? I think half of the investigators thought they would, half of they wouldn't. It really depends a lot on what's available in your practice. Manish, have you ever done it?
Well, I was going to say, this is the question that gets you invited, right?
Yeah.
No.
That's a good joke. Yeah.
No, I haven't done it. But I think one thing that we might think about. Clearly, zanidatamab seems like it's a better way to target HER2 than trastuzumab. Trastuzumab deruxtecan is also a better way to target HER2 than trastuzumab. There's data, as we reviewed, that trastuzumab deruxtecan works in trastuzumab failures, but we don't have the data of trastuzumab deruxtecan in zanidatamab failures. And so, although we all said the same thing, that we would use trastuzumab deruxtecan, I guess I wonder, is that a concern?
Eric, what do you think?
I don't think it's a concern as long as we retest the patients after progression on chemo, zanidatamab. If we retest the patients, as you said, Yelena, that's a preferred option, and the tumor is still HER2 positive, then I would consider trastuzumab deruxtecan.
Yeah.
That's good to hear. So, I think the question about loss of HER2 is a real one, especially since the lifetime of these patients, we need to offer as many options as possible. And I think, it would be good to know, for example, in your practice, Manish, do you always rebiopsy or do you follow ctDNA? What do you do?
Yeah, no, I try to rebiopsy when it's available. I don't use ctDNA that often. I know it is accepted if it's positive, but if it's negative, if a patient's not shedding, I worry that I miss it.
Okay, and Eric, do you think, so the anecdotal data or unpublished data that I've seen is that the rate of HER2 negativity after Zani progression, as I think Manish alluded to, is higher. So in terms of total available options, especially, as we want to be able to offer patients T-DXd in second line, does that deter you from using, zanidatamab in first line?
No, because I think the survival data are so strikingly positive with long-term survivals of over 2 years, as I've shown. So that I think the best for the patients is still to go for the best treatment in first line. So I would go for FOLFOX checkpoint inhibition and zanidatamab in first line, and then see if at a certain moment the patient is progressive, retest him, and then if positive, trastuzumab deruxtecan.
That's great. Okay, so outside of the clinical trial, have you administered or would you administer trastuzumab deruxtecan to a patient with HER2 low, IHC2 or 1+, so a FISH negative, if IHC2+, gastric or G-junction adenocarcinoma? So I think the question is, most of us are intrigued by the emerging data. I think the question is T-DXd going to be sufficient? And I'm curious, especially with the combination with TKIs, Eric, if you've had any experience using these or would use it in the practice, because certainly preclinically, it's compelling reason to increase the HER2 expression using irreversible TKIs, for example.
Yeah, there are new TKIs indeed under development that very early data, that phase 1, early phase 2 data that show clear activity in this setting. But if you look at the data here in the question on trastuzumab deruxtecan, the trials have shown that in the initial Japanese study, there were cohorts with HER2 low patients also, and the activity was very, very, very modest of TDX in this group of patients. So I would then rather go and explore for a trial, if possible, with one of the new TKIs.
Mm-hmm. This is a very great, insightful question from the audience. Let's pose it in first line. Do you consider different HER2 levels of expression in gastroesophageal cancer before choosing HER2 targeted therapy? So, for example, if somebody is IHC2+, FISH positive, versus IHC3+, do you lean toward more complete HER2 blockade or dual HER2 anti-PD-1? Let's say in both of those scenarios, PD-L1 level is CPS5 to make it complicated. Maybe Manish, you start first, and then Eric, you can weigh in.
So that's a really great question.
I know.
The subgroup analysis from the Horizon study suggested, at least in the forest plot, that if you're HER2 IHC2+, you had maybe less benefit. So the zanidatamab, with its biparatropic, design, it seems to be really quite effective in when the expression of HER2 is higher. And so I think it's a great question. I think in my approach, I would probably still take what Eric said to heart, that what we've learned in GI cancers is that if you have a target, the earlier you attack that target, the better the outcome. And so even if you're HER2 2+ and FISH positive, I would still use Zani in that setting.
So Eric, I'm going to amend my question to make it a little more nuanced, because I like to ask you hard questions. If, for example, T-DXd data reads out DG05 is positive, and now you have 3 options in first-line setting, and the patient is HER2 positive by IHC2+, are you more compelled to use an antibody versus an ADC in first line?
Well, we have to be very careful with doing too much subgroup analysis of the different trials and subgroup analysis of the ADCs and the bispecific antibodies of 2+ versus 3+. We should not forget that HER2 is quite heterogeneous in gastric cancer, is a driver, but probably less a driver than in breast cancer in this setting. So depends of the degree of positivity of the Destiny-05. Suppose that there is also a similar benefit with a median survival of 26 months. Then toxicity profile probably will dictate more my choice than this with the data we do have today.
So the off-target effect or the bystander effect, rather, you would TBD, right? We'll see. Great. Well, I think it's time for our next speaker, and Dr. Shah will talk about targeting Claudin in advanced gastroesophageal cancer, and we do have Claudin questions from the audience, which we'll get to, I promise, which is, please, Manish, go ahead.
Thank you. Great. So it's nice to be here, and thanks for having me. So we'll talk about the other target that recently led to an approval, and that's Claudin 18.2. I start off with this slide, one to highlight the different targets that we're thinking about in upper GI cancers. Of course, unfortunately, the FIGHT data was negative, but FGFR2, I think, is still a target. There were large studies for MET, and those were negative. But Claudin, PD-L1, of course, for immunotherapy, HER2, MSI high, these are all, now if you look at it, we're taking about 2/3 of the pie already, and it's just really quite exciting. But this is actually not the right way to look at these targets. It's actually more like this, where there's overlap, and that's actually the challenge. The challenge is, what do you do when you have dual expression of the targets? Because most of the studies were evaluated in a setting where you excluded patients with one target, for example, HER2, and you didn't test the dual evaluation, at least until now. So, with regard to Claudin, this is a tight junction protein, and it essentially, as cells become malignant, they have their malignant transformation, they lose their tight junctions, and the protein becomes available, and it can migrate to either end of the cell, and cells lose polarity. The other way to think of it, and I think this analogy, at least for me, works well. If you imagine a white picket fence, and the hinges between each of the spokes is a tight junction. So then, if you lose the hinges, those screws, they become available, and then you get malignancy, and you can now also kind of target those hinges. So that's kind of how this works, and it's shown here as well. So the tight junctions, as you get malignant transformation, you get expression and availability. So essentially, the targets that we have take advantage of that in cancer you have prevalence of this target, and you can use that to activate an immune response potentially, or deliver drug. Dr. Klempner's group did this analysis just recently published in ESMO GI, which is really quite interesting. So it's cut off a little bit, but the over here is the tumor size. So this is esophageal, and this is gastric. So we pretty much see that HER2 prevalence is significantly more prevalent in gastric cancer than esophageal cancer. And that's the key message from this slide. And then down here, using 75% as the threshold, you can see that maybe 30% of tumors are Claudin positive only and don't express any other target, and about 25% are the new triple negative. Claudin negative, HER2 negative, and PD-L1 negative. So we need new treatments for this last option. But then for the majority of these tumors, there's going to be overlap. And what do we do when there's overlap? So that's, I think, a very illustrative slide and graph. So, of course, these are a couple years old now. The Spotlight study was a study of FOLFOX with or without zolbetuximab. Zolbetuximab is given every 3 weeks. FOLFOX is every 2 weeks. So there was like a kind of a weird off-cycle schedule. That was one registration study. Another registration study was the GLOW study, and that was CAPOX plus or minus zolbetuximab. And we actually combined them. So each of these studies was positive, and we combined them in a single analysis because the backbone, FOLFOX and CAPOX, are equivalent, at least in efficacy. And so this is the combined analysis, and you can see, quite nicely that zolbetuximab does add, improvement in progression-free survival, and these curves are illustrative. I think one thing that we think about for immunotherapy is the tail on the curve, the sustained anti-tumor immune response that you can see with immunotherapy. You're seeing a similar effect with zolbetuximab, indicating that zolbetuximab is in fact potentially activating an immune response that can be sustained. And then this is the overall survival, and you can see at 3 years, 11 versus 20%, which is, quite significant. I mean, I think many of you who see patients, we talk about medians all the time. In front of you, the patient never thinks that they're the median. They think that they're going to be on the tail. And so if we can extend the tail, I think we give them a better chance. So this is a busy slide. The main side effect of zolbetuximab is nausea, vomiting. It's acute nausea, vomiting. It happens when the drug is being administered. It's almost, it's like a Pavlovian response. You're getting chemotherapy, no problem. You get this new bag. It has a little bit of chemotherapy, brand new drug, and as it's being infused, you feel nauseous. So addressing this nausea right away and aggressively is really quite critical. And what's shown here is that the nausea is actually primarily in cycle 1 and cycle 2. So if you can get past that, patients can actually have benefit. And that's actually what's shown in the graphs in terms of the global quality of life, the abdominal pain, the physical functioning. All of these favor zolbetuximab, but primarily at the tail when patients have been on it for a sustained time. So in terms of managing nausea, vomiting, a key thing is, one, give full antiemetics. So in the trials, steroids were not initially used because we didn't want to avert a immune response. But it's actually probably better to use steroids, use NK1s and 5-HT3 inhibitors. But if you're having any significant nausea, pause the infusion. Pause the infusion, wait a little bit, let it settle, maybe give some, another antiemetic, and then resume the infusion at that rate, and often patients are able to get through it. So the first dose of zolbetuximab is a loading dose. It's a bigger dose, 800 milligrams per meter squared. So it takes longer. And if you're giving that with FOLFOX, be prepared for being in the chair for a full day, or be prepared for the patient to come back the next day. So in the United States, most people are in an outpatient setting. That's not true, in Asia, Japan or China, where they can often admit patients and you can manage it over a couple of days. So that's a key difference. I think if you're prepared, if you're able to manage the nausea, go slow, make sure that patients are aware they may need to stay late or come back the next day, you can get through it, and then you can really see the benefits moving, later on. I think that's a really key important point. So the Illustro cohort addresses this question that I raised at the very beginning. What do you do when you have dual positivity? So here, if you're Claudin positive and PD-L1 positive, this is a randomized phase 2. This is a phase 2 study of zolbetuximab and nivolumab. We'll focus on cohort 4B because that was the expansion phase, 65 patients, and you can see that the addition of nivolumab to zolbetuximab was actually really quite impressive. The 1-year PFS of over 60%, and if you look at the waterfall plot at the bottom, you can see that the majority of patients had some response, and very few patients had progression. So, I'm just going to pause here for a second because chemotherapy, we're talking 30% response rates. But now when you're adding targeted therapies, zolbetuximab or trastuzumab and pembrolizumab, you're getting response rates 50, 60, 70%. It's really, really quite impressive. It's almost like, us GI docs can be treating lymphoma. It's high response rates. It's really quite encouraging. In terms of the toxicity, no new adverse side effects were seen. And here again, the main thing was nausea. On this study with very good prophylaxis, there was 0 grade 3 nausea, so that's a key thing. And then you do see about 40% of patients having some neutrophil decrease and about 30% having grade 3 neutrophil decrease. So the Lucerna study is taking advantage of this and examining the addition of pembrolizumab to zolbetuximab and chemotherapy in a randomized phase 3 study. And the Zelda study is looking at zolbetuximab in the second-line setting with nab-paclitaxel and ramucirumab. This is also an important study, I'd point out, because at least in the United States, reimbursement for zolbetuximab right now is only in the first-line setting, as is immunotherapy. So, patients and physicians have to make a decision if you're both Claudin positive and PD-L1 positive, which do you choose? And so having some data like this to allow for the use of a targeted agent in the second-line setting would be really quite important. And then, of course, here at ASCO, a trial in progress is this rain spot study that looks at, again, zolbetuximab, paclitaxel, and ramucirumab in the phase 2 setting. So take a look at this trial in progress. I think that's my last slide. Oh, I just wanted to say one thing here. So trastuzumab was approved in breast cancer in 1998. It was approved in gastric cancer in 2010 or 2011, so 13 years. And then, the advances that Yelena and Kohei made with regard to adding pembrolizumab or trastuzumab deruxtecan, another 10 years. The pace of drug discovery and drug development is exponential. So zolbetuximab is approved 18 months ago, and even before approval, there are 30 new drugs that are being tested in the phase 2, phase 3 setting. They're monoclonal antibodies, they're CAR T therapies. It's really exciting data that was already presented last year at ASCO, bispecifics, and ADCs targeting zolbetuximab, or the Claudin 18.2.
Great. Well, thank you for that summary and the overview of the data, especially the toxicities. So let's get through some questions. We're back to our 65-year-old patient with metastatic Claudin positive, HER2 negative, microsatellite stable gastric cancer. And as we often see with these tumors, the patient's cancer is PD-L1 CPS 0. So all of the biomarkers were done, and it looks like it's a unanimous decision to use zolbetuximab in first-line setting in combination of chemo. So perhaps let's dive into the chemo question part of it. And also what I would like you to comment on, maybe we'll start with Eric, is how often do you actually use FOLFOX versus CAPOX? And practically, do you bolus Zolbi, or do you do the initial loading dose, or do you skip it?
Yeah, we use always FOLFOX in all our gastric cancer patients or G-junction and esophageal cancer patients. So we never use Capox in this setting with whichever combination, with the checkpoint inhibitor, with HER2, with zolbetuximab in this situation. We usually use the loading dose of zolbetuximab per protocol in the first cycle, and then later on we decrease a little bit the dose according to what Manish just presented.
And Manish, the emerging data from Kohei and others is really concerning, showing how variable the claudin expression is, which of course we know the disease is quite heterogeneous. If you see a patient, let's say this patient had a HER2 negative tumor but claudin positive in the primary, but you happen to retest the liver metastasis that you also have, and the liver met is claudin negative, would that change your opinion about using Zolbi in the first line setting?
Yeah, that's a good question. I don't think we don't know the answer to that. I think the study allowed any biopsy that showed positivity. So we don't know if that may explain why the response rate in GLOW and Spotlight wasn't that high, but the survival was better, because maybe there were some areas that didn't respond because they didn't have Zolbi. I don't know, but I would still use Zolbi in that setting.
In that setting, if there was an available trial for a bispecific with claudin, let's say an IO or a T-cell engager, would you lean toward combo with that, or does that change anything?
Yeah, no, I think any novel therapy I think would be very, very interesting. I think bispecifics have very good activity, ADCs have very good activity, and so I think that I would try that for sure. If the patient had any tissue that was claudin positive.
And Eric, which antibody do you use for claudin testing? Do you think you need to adhere to whatever is in the package insert, or are they all interchangeable? And do you think transcriptome may be better? This is an audience that came question.
Yeah, we don't use transcriptomics. I don't have any data. We use the commercially available antibodies that is in the package insert and that is approved globally as well in Europe as in the US.
Mm-hmm. All right, so our next question is, again, the patient is claudin positive, HER2 negative, MSS with PD-L1 CPS1. So this is probably the biggest question that's still in the debate, and many of the investigators are leaning toward, of course, use of combination therapy if feasible with Zolbi anti-PD-1. I'm the outlier here with anti-PD-1 therapy with chemo. So maybe, Manish, what are your thoughts about use, practically using immunotherapy versus, claudin inhibition? What do you see folks in the community getting, and what's practical for our patients?
Yeah, no, so I think that this decision is also largely made from a practical standpoint and toxicity. I think in the community, zolbetuximab is difficult to give. The infusion rooms are just not prepared to manage the toxicity, the duration. It's, in the United States, time in a chair is money. So I think that in the community, I think there is, a preference for an anti-PD-1 or PD-L1 antibody. I think the difficulty with this question is that we don't have a biomarker that differentiates yet, and I think that's where the energy should go, to identify what the patient that would benefit from one, not the other.
Mm-hmm. Yeah, absolutely. And yes, of course, practically, I think zolbetuximab is a difficult drug to give, and for our patients who don't have access to anti-PD-1 therapy in first line, in subsequent lines, second or third line, unlike Asia in Japan, where nivolumab is approved in third line, it becomes a struggle as to what biology do you think is the most important, and I think it's decided based in general in the combination with the patient discussion and so forth. I think in the United States, chair time is critical, but also admissions, where hospitals are over capacity constantly, and these patients have to wait in urgent care for a long time. In Japan, patients get admitted for this therapy for continuous monitoring and anti-nausea medicines. So I think for our patients, practically an 8-hour day is not the reason why they want to get anti-cancer therapy. And so my patients elect usually to get anti-PD-1. So this is a patient with CPS 10, and in this case, with combination, again, Dr. Weinberg is the outlier, going with Zolbi-based combination, which I think is a very reasonable approach as long as you're aware of toxicities and issues that arise from that. Next slide. Okay, so here we have indirectly compare global efficacy of zolbetuximab and chemotherapy to that with anti-PD-1 antibody and chemotherapy for patients with newly diagnosed gastric and GE junction adenocarcinoma who are eligible for both treatments. So I think most people agree that it's about the same. And then Dr. Kim and I believe that perhaps anti-PD-1 therapy is a bit more efficacious. I think some of this data is coming in, at least from my bias in my clinic, and I'm sure in yours, where most of our patients are actually GE junction tumors as opposed to distal gastric cancer. And most of our patients have distal esophagus GE junction cancers. And we know, at least again, and I think I have some of that in my slide, or maybe we took it out, but piecemealing some of these little strands of data suggests that GE junction cancers don't benefit as much, perhaps, for anti-claudin, and they benefit more from anti-PD-1. And also because you're going for deep responses that you need in first-line setting, again, anti-PD-1 therapy may be bringing that to you. But Eric, I want to give you a chance to weigh in on this.
Yeah, you're right that the subgroup analysis in Spotlight and Glow, but that's a subgroup analysis, showed that the benefit was lower in the G-junction compared to the non-G-junction adenocarcinomas. But again, that's subgroup analysis, and we have to be very careful in this setting. So that's why we don't have head-to-head studies. Of course, we do have more studies with anti-PD antibodies, but if patients are Claudin positive and PDL positive, if you look at the hazard ratios for survival, that's approximately the same with all the limitations of cross-trial comparisons. That's why I replied here about
Manish, you wanted to weigh in. And does the use of anti-PD-1 in first line attract you with a response rate and also the lack of availability in later lines? How do you think about it?
Well, so what I was going to say, thank you, is that with the anti-PD-1s, we actually have 5-year survival data with both pembrolizumab and nivolumab, and it's significantly better than not having it. So, and we don't have that data for zolbetuximab. So that, I think that is probably a very good reason, why you might consider that.
Okay, so I guess I'll put another wrench in the story, particularly since a question came in about EBV testing. EBV obviously is a known cause of gastric cancer. Those tumors are usually PI3 kinase mutant, have PD-L1 overexpression. But do you test for EBV typically, and would that change anything? Because we've ignored EBV in our discussion today.
Yeah, we have been looking at all our patients. We have tested all our patients, but at least in our setting, and I'm speaking several hundred patients in Leuven, EBV positivity rate was low, much lower than what is reported in literature. And there are some other studies also who've shown recently a lower than expected positivity rate. And there is overlap with PDL. Most of the EBV positive patients are PDL positive. So we don't test for it anymore today outside of studies.
Okay. Manish, what about if you have a CPS1 patient that's EBV positive and Claudin positive? What are you going to do in first-line setting?
Yeah, that's a good question. So I think, 70% of patients who have an EBV subtype of gastric cancer have PD-L1 expression, and it's almost very rare to have just one. It's like 50, 60. It's really high PD-L1 expression. So I think that's the driver of efficacy more so than...
except PD-L1 tests fail. That's the problem, right?
Right.
I think we put too much weight. EBV is much more kind of...
Robust.
Yeah. So let's say you don't believe the PD-L1 test, but it's CPS1.
I see. Yeah, that's a good question. I guess that might be the case where I might try to do the combination.
Yeah. Interesting. Good. That's a great answer. And a question also came in for HER2 mutant gastroesophageal cancer. Let's say if you have external domain mutation that's known mutation that's described in Cosmic, HER2 negative tumor. Let's say it's PD-L1 positive, CPS 3 with Claudin positivity. Would that sway you toward one therapy or another for HER2 mutations? Would you be tempted to use zanidatamab?
For HER2 mutations, the new TKIs, there is a new TKI that has shown very nice results in lung cancer, HER2 positive, but also very preliminary data have shown that there is activity in HER2 mutant gastric cancer with sorafenib.
Zongertinib, yes.
Yeah, in this setting. I would look for a trial if possible. Outside of a trial, I would not do zanidatamab if the patient is HER2 negative with the classic criteria.
Okay. So let's get back to our patient. So outside of a clinical trial, have you administered or would you administer both Zolbi plus anti-PD-1 in combination with first-line chemo? And I've confessed that I have. It seems like some of the investigators in the panel have, but perhaps others have not been so bold. So, of course, time will tell, and the definitive phase 3 study finished accrual, so we should have the results soon. But why don't we ask about, and Manish, I know you said that the data is coming, but in the current phase, since, Claudin inhibition became approved and available, and there's many patients who did not get it in first-line setting. So now you have a patient who's coming in, Claudin positive, just progressed on FOLFOX/nivo. You don't have, SUN-EV study open, or you don't have access to any Claudin inhibition in second line. And it's a young patient. Cost is not an issue. Would you use Zolbi in second line? And how would you use it?
Yeah. So the Illustro phase 2 study, we published that. There was a small cohort in the advanced line setting with zolbetuximab. The activity was not as strong as we had hoped, but that was monotherapy and with pembrolizumab. So I think we just don't have the data, and I guess I think I would really search for a trial. I think that targeting Claudin is a good idea, but I think outside of a trial, I would feel it's a lot of toxicity with unknown benefit.
Would you use it with 5-FU as Dr. Wainberg suggested, or would you combine it with paclitaxel ramucirumab in second line?
I need to visit UCLA and see what they're doing. No.
There are credit cards everywhere in Hollywood. So would you use Taxol-Ram or would you use 5-FU?
So I would probably use...
Or not do it?
I'd probably not do it, okay. or use it with the 5-FU.
Sticking to your answer. Yeah. You're holding firm. I like it. Unswayable. Okay, great. And let's maybe do some more questions, or do we have another slide? Okay, great. So I think the question about endoscopic rebiopsy. So I've had patients like this, actually, especially as we're doing combination therapies with, the next generation bispecifics and anti-Claudin, where the patient is behaving as if they're progressing, you do an endoscopy and the biopsies are negative. How often do you use endoscopies in your practice to assess primary tumor? How do you sort of navigate these neurotoxicities? As you know, as Manish so eloquently summarized, the claudin inhibition can really do a number on your mucosal membranes. So how do you advise the patients and the practice?
Yeah. So the question was,
do you always biopsy endoscopies to confirm progression and to follow a response in the primary tumor?
Yeah, no, I rarely actually use an endoscopic biopsy to evaluate for progression. It's just so challenging because the symptoms of dysphagia or early satiety can happen even when you're having a response.
Yes.
So it's actually, I think, challenging to do that. I think endoscopic biopsies are really valuable if you're trying to reassess for the the toxicity, what's going on from that standpoint, or also from a standpoint of the biomarker expression. But for response assessment, I think it's very challenging.
And Eric, what are your thoughts about emerging data on other targeted therapies such as B7H3?
Such as what? Sorry.
B7H3.
Don't have any experience.
Okay. In terms of in long-term survivors, let's say it's a HER2-positive patient or a claudin patient on maintenance therapy for 2 years. As you see here, people live longer and longer. When do you stop? How do you advise them?
That's a highly individual decision. So if a patient is on zolbetuximab without toxicity, and I've had several of these patients with quite long duration of response. So of course they started with Folfox zolbetuximab. I took off oxaliplatin, and then after a certain moment I took off 5-FU and went on quite long, a couple of patients more than 2 years with zolbetuximab. And that's a highly individual decision. Usually the conundrum is to continue until progression or toxicity, but at a certain moment, at least in Europe, patients wants to go to the Mediterranean to have 2 months of vacation, and then we may interrupt it further.
Yeah, that's great. Well, we're in the home stretch to Module 3, and I will be taking you through available immunotherapy strategies for gastroesophageal cancer. As you heard today, we have many options, and the biomarker testing is critical. So in the current state of affairs, if you're seeing a patient with adenocarcinoma, the important biomarkers are HER2, MMR, PD-L1, and of course, claudin. As was recently demonstrated, FGFR2b is not yet prime time for testing, and so we can put a pause on that, but really immunohistochemistry is an easy way to know within first 3 to 4 days of seeing the patient of which targeted therapies are available, and it's an important first step. If you're seeing a patient and there's not sufficient tissue, please consider doing an endoscopy because this is to repeat the biopsy because that's critical. For patients with MMR deficient tumors, both chemotherapy and immunotherapy, dual immune checkpoint blockade, or anti-PD-1 therapy alone are good options. We decide based on patient functional status, concerning for disease heterogeneity, and how fast you need the response to happen. For HER2-positive disease, as was mentioned, currently we have combination with trastuzumab-based therapies, and with Horizon data coming out, we will likely get zanidatamab on the formularies. But that's to be determined. And of course, for PD-L1 overexpressing tumors, we currently are looking at several available agents, including pembrolizumab, nivolumab, and tocilizumab, and there's many other very effective anti-PD-1 agents available in other parts of the world, such as sintilimab and others. And you'll see data at this meeting coming out from investigators in Beijing University and others. For claudin inhibition is critical for a subset of patients. I would put that, as was indicated here, on the priority as a fourth biomarker of priority in terms of efficacy and long-term survival data that's available and the ease at which to give it. But there are a population of patients that are HER2 negative, PD-L1 low or negative, that are claudin positive, that are critically helped by these class of drugs, including zolbetuximab. So, of course, Checkmate 649 is the first study to definitively move the bar for patients in median overall survival, clearing the 1-year mark. And this was a large phase 3 study that we conducted with initial goal to dethrone FOLFOX and to give nivo-ipi an option in first-line setting. But suffice it to say, the two arms that compared FOLFOX or Capox nivo or Capox or FOLFOX alone were the winners here, and there's clear evidence for survival benefit and progression-free survival and response rate for addition of nivolumab to standard first-line chemotherapy. And we just recently published the 5-year survival, and there's going to be 6-year survival and so forth. So to be able to look at a patient in the eye and say there's a very good chance you will be alive, living with this disease, is quite reassuring and makes us all hope for a better future for these patients. And the number one predictor of likelihood of being on the tail of the curve is the response rate. And having to have had an early response at early scan is a really good sign that this patient will continue to do well. This benefit, of course, is augmented by the level of PD-L1 overexpression. It's a spectrum of PD-L1 overexpression. And as we know, PD-L1 is fraught with all difficulties that we discussed at different meetings. But it's good to see that PFS, progression-free survival, is also improved significantly with early and sustained separation in these survival curves with hazard ratio 0.7. And the 5-year overall survival, again, it's approximately 17 to 20% of patients are alive. And this is, global phase 3 studies before the rev-up of, Claudin therapies and other therapies in second-line setting. At a tertiary cancer center like ours and others in a specialty cancer care, these patients live beyond 5 years. They live, and again, most aggressive first-line therapy, but also continuing on second-line therapy and beyond, and symptom control is what determines whether or not you're going to be alive. And doing PD-L1 testing, doing biomarker testing is a mark of, a specialty care. And so, again, helps these patients live longer. Progression-free survival is also improved. Checkmate 648 was a similar study that looked at this regimens in squamous cell cancer. And squamous cell cancer is an interesting cancer because it does benefit from combined immune checkpoint blockade differently than the adenocarcinomas. So Nivo3 IPI1 was successful in this group. But we also do know they benefit with chemoimmunotherapy. And unfortunately, overall, though, these patients tend to do worse because they're unlike adenocarcinoma. There's less biomarkers, HER2, and so forth, and there's less targeted therapies available in subsequent studies. So, but the 5-year Checkmate 648 survival further support Nivo chemo and Nivo IPI in first-line standard of care patients. Maybe I'll take a question later about who do we actually use Nivo IPI in. So we'll get to that. And of course, Keynote 859 reinforced what we learned from Checkmate 649, showing that pembrolizumab, in addition with chemotherapy, is also effective. So in this case, as we know, pembrolizumab is given every 3 weeks or every 6 weeks dosing. So it really lends itself well to no matter what regimen you pick, you can decide what immunotherapy to choose. And intention to treat population, there was an improvement. And then again, PD-L1 CPS greater than 1, there's clear benefit. And although initially the FDA approved PD-L1 nivolumab irrespective of PD-L1 status, now a year and a half, 2 years ago, the ODAC met and amended that approval for CPS greater or equal to 1 cutoff. And the benefit maintained at 4.5-year follow-up. And again, there's a clear dose-response relationship where you see that PD-L1 score of CPS 10 patients, there's a really obvious benefit with early and dramatic sustained separation, but there's a benefit for CPS greater than 1. And the concern here is not that, we think PD-L1 is a useful biomarker. It's the concern of how reliable it is, especially at lower levels, especially in patients who may not have stromal component to their tumor. And again, it may not be as reliable in clinical practice as it is in phase 3 prospective trial setting, where the mandate is to have tissue block, 20 unstained slides, and the patients are not even allowed to enter the study if the tumor quality is not sufficient. Keynote 590 was a similar study, but squamous cell is included predominantly in this study, and similar to 648, again, showed a clear benefit to addition of immunotherapy in a first-line setting for squamous cell cancers. These patients can be quite sick, so we do need a deep response. Most of our talk was focused on adenocarcinoma, but squamous cell, don't forget those patients. Of course, they need immunotherapy in first-line setting. And once again, it's just great to see benefit again, carrying and maintain at 5 years. Rationale 305 used tislelizumab in combination with CAPOX, and tisle, of course, is important as we're entering the era of dual zanidatamab plus tislelizumab, because that's the drug that is used in combination with zanidatamab. And, it was a very strategic partnership for them, and it really, they're putting their stake in therapies. I think before the Horizon data, many of us, were sort of still thinking of tislelizumab as another option, but not maybe a main option. But the Horizon data is changing that a bit. So the addition of tislelizumab showed overall survival benefits. So it's a great drug, especially for patients with high PD-L1 overexpressing tumors. There may be some thread in the literature about peritoneal disease treatment and so forth. But the benefit is once again maintained at 5-year follow-up. So the future is really looking, ahead for combinations. Squamous cell cancer is an important disease to continue to study. Immunotherapy works in this disease, but the benefit as well is maintained at after 3 years. We just need to have better subsequent treatments for these patients. So tislelizumab is included in treatment for squamous cell for NCCN guidelines as February of 2026, but so is nivolumab and pembrolizumab. So the guidelines feel a bit overwhelming, and I think I get a phone call a lot or a text or WhatsApp from friends and colleagues saying, wait, so what do I do? Because sometimes, it feels like you're reading a package insert for a medication, and you're like, well, but what is it actually that I need to do? I think in summary, you need to biomarker test these patients, and you need to use at least some form of immunotherapy or perhaps a targeted agent. But immunotherapy is very effective, and it doesn't matter what immunotherapy you use as long as you use it in combination with fluoropyrimidine platinum. Immunotherapy is promising, particularly CTLA-4 inhibition. Unfortunately, Checkmate 649 did not pan out without the chemo, but we knew this was a trial we published in 2018. In later lines, IPI was quite powerful, and if you had a response to IPI, even in non-MSI, non-EBV patients, you were likely to be very durable responders, and I have patients who I treated on the study who are still cured, more than 10 years later. So with that, I think check out the data from Attraction 6. It's presented in an oral session Monday, June 1st. I think combination with FOLFOX and IPI is quite, tricky. So stay tuned for that. So I think we have now, we're in the final Q&A session, and we'll kick it off with another patient who is 65 and had a CPS 0 cancer, HER2 negative, Claudin negative, G-junction adenocarcinoma. And I think I have to defend my position as an outlier. And I'm not embarrassed to say that I would use nivolumab in this setting. And I have used nivolumab in this setting. And in fact, the FDA, as of recently, had nivolumab approved in this setting. So I find that the decision to use these drugs have to be carefully assessed, because those patients were included in the Checkmate 649. We know it's safe. We know that the response improvement is still there. And we know that PD-L1 is not a reliable biomarker. In fact, if you call your pathologist and ask them, hey, this is CPS 0, How much stroma is in the sample? Is it truly CPS 0? What antibody did you use? Because, the different PD-L1 antibodies have different sensitivity for stromal versus tumor component. You likely will get a CPS 1 answer, and we'll change that, which I've often done with our pathologists. But Manish, what are your thoughts on that rationale? And do you honestly don't use immunotherapy in those patients?
Yeah, so you make very good points. I think that there is some unreliability. I think that the concern, the challenge that I have is that there is a low rate of toxicity from immunotherapy, and it's idiosyncratic. So, I've treated patients who developed adrenal insufficiency, and then now for life they have to wear a band, for their, stress dose steroids or things like that. There's a rash, there's fatigue. So I think weighing that potential risk for toxicity for the possible benefit in a CPS less than 1 population, I think that's why I answered that way. But I think you've been consistent in your thinking to use nivolumab in this setting. I think it's not unreasonable.
Great. Okay, so here a patient, 65-year-old, presenting with metastatic claudin negative, HER2 negative, MSS G-junction adenocarcinoma with CPS 1. So Eric, maybe you can go through the different anti-PD-1s that are available, and do you think about one or the other? How do you decide?
Yeah, in fact, I don't think there is a clear difference between the activity of Nivo, Pembro, and tislelizumab, the 3 approved checkpoint inhibitors in different regions. The reason why I answered Pembro here is that it's a little bit driven by the label and the data that you've shown, where the analysis was done for PDL CPS 1 and 10, while Nivo, the analysis was done for PDL CPS 5 or more in this setting. And the study with Pembro with the PDL CPS 1 was positive, while we don't have clearly the data just for the subgroup of Nivo with PDL CPS 1. But that's influenced also by the label. In Europe, the label is for Nivo CPS 5, for Pembro CPS 1.
And how many months of therapy do you continue, Manish, usually, or years?
Yeah, so, I think I dropped the oxaliplatin at roughly 4 to 5 months, and then I tend to continue 5-FU and the immunotherapy, the checkpoint inhibitor, up to about a year, 18 months, and then I drop the 5-FU at that point. I don't have probably as many long-term survivors as you do. Do you continue immunotherapy alone?
So it's a good question. I think it depends on level of PD-L1 overexpression and if they're MSI, for example, and sometimes we use imaging and endoscopies to decide. Most of our patients are very difficult to convince to stop therapy.
Yeah.
Even in MSI setting where, I think the area that I definitely stop is MSI. Usually I convince them at year 2. At the end of, and usually if the endoscopy is negative and the biopsy is negative, ctDNA is negative, and they had baseline ctDNA we followed, and we do use PET scans closely to monitor them. For patients with metastatic non-clinical complete response, so the endoscopy shows persistent disease, but otherwise under control, we usually continue capecitabine with monthly anti-PD-1, usually nivolumab or pembrolizumab, and of course there's now sub-Q options.
Yeah.
So the patients quite love that flexibility.
Yeah, I mean it's a good problem. It's a good problem to have.
Amazing
right?
problem. Amazing. Okay, so here's a 65-year-old patient, HER2 negative and claudin negative, MSI high. When I see that in the clinic, I'm in a good mood for the rest of the week. G-junction adenocarcinoma, CPS 1. That's a very good question. I may have written it, but it's true. So if you have PD-L1 low patients, it doesn't mean that you don't need to test for MMR. You have to do it. Sometimes you see that. And then, of course, in this patient, it's very important to do germline testing because you may see Lynch in a setting of GE junction tumors, Lynch syndrome, although it's rare. And then alternatively, it's true, just because you're seeing a Lynch patient, do not assume that their cancer will be MSI high. We've seen that those tumors are sporadic, sometimes are in MSS. So let's go back to our patient. So MSI high tumors, Eric, how do you sort of balance dual immune checkpoint blockade or chemo? What do you feel most comfortable with?
Yeah, the correct answer is probably that there are two options. So that's double checkpoint inhibition or chemo plus checkpoint inhibitor. Usually in many patients in this situation, I favor to start with chemo plus check plus nivo, but with, as was written there in the long answer, with a low threshold to drop the chemo. So a couple of cycles of chemo and then dropping probably the chemo and continuing with checkpoint inhibitor.
So Manish wants to get, we agree, but I'm going to make it a little difficult and say, what about it's not a first-line patient? It's locally, for Manish, locally advanced, non-metastatic. Does that change your question or answer?
Yeah, so that's a great question. So there are some phase 2 studies that suggest that dual checkpoint inhibition might be quite effective there. And in the locally advanced setting, we're thinking about an organ-sparing approach. And so in there, I would be more inclined to do Ipi-Nivo in that setting. That being said, I have done FOLFOX-Nivo and then dropped the chemo. The challenge is that in MSI high disease, the chemotherapy could potentially limit your efficacy. At least chemotherapy alone we think is bad. So chemotherapy with immunotherapy, I'm not sure, maybe the immunotherapy is just offsetting that.
Mm-hmm. And in patients who in an era of Matterhorn, which is we didn't talk about today, but let's talk about perioperative therapy. So the patient got flawed durva, completed a year of durva, let's say, and then recurred. When do you consider rechallenging them with immunotherapy in first line?
I would look, of course, at PDL testing and the other markers that we discussed already. If patient continued with 1 year of durva and then as a relapse, later than 6 months, there is no doubt, I would for sure reintroduce chemo plus checkpoint inhibitor. If it's shorter, I would probably also do, but then in combination with chemo, because these patients stopped already the chemo since longer time.
That's right.
And so I would probably, if the patient recurs 3 months after stopping durva, I would probably, and the tumor is PDL positive, clearly PDL positive, I would probably restart them with chemo plus nivo or pembro.
And would you be, but let's say if it's a claudin positive tumor, are you more than likely to use a claudin inhibitor instead of anti-PD-1?
If the tumor is clearly claudin positive, then a slight trend towards a preferred option.
And of course, if the patient is gastrectomized, nausea is not a problem. So that's an advantage. There's a good question also came in about, and Manish, maybe you could take this one. It's just so disappointing that we don't have immunotherapy in later lines. And of course, Attraction 4 was mostly, only Japan study. But do you ever find a scenario where you would use immune checkpoint blockade in relapse refractory setting, second or third line?
Yeah, so, and I've done it. I've done it in a setting where the first experience with immunotherapy was successful. Mm-hmm. Not 3 months or 6 months, but like 18 months, 24 months. And then, patients stop therapy, they move on. And then if they have progression, I try to re-challenge at that setting. But if the first experience with immunotherapy was not successful, I rarely try immunotherapy again.
Yeah, great. Okay, so this is a patient with squamous cell cancer. So different disease, claudin negative, HER2 negative. PD-L1 is, so there's two scenarios, CPS 0 or CPS 1. It looks like there are some differences in opinions about use with anti-PD-1. And for squamous cell cancer, the majority agree that maybe PD-L1 is not as important biomarker as it is for adenocarcinoma, and we could use it irrespective of PD-L1 status. Eric, since you were a little bit of an outlier, can you kind of review the data for us in that sense?
Yeah, indeed, PDL is a biomarker in squamous cell cancer, and the more positive the tumor is, the more likelihood the activity is in this setting. And if you just do the analysis and look in the patients with a really PDL negative tumor, then I'm not convinced that there is any benefit for adding Nivo or Pembro over another checkpoint inhibitor. Of course, the analyses that are usually presented are then patients with any, so the intention to treat with any PDL testing result, and then the trial remains positive. But if you take out PDL negative, I don't think the threshold of having a clear benefit is not there.
And of course, unlike adeno, where you use immunotherapy in first line or you lose it, in squamous, we do have approval of immunotherapy in second line, both alone and in combination with chemotherapy. So there is that. But I agree with myself and others that if you don't use it in first line, you may not get it to second line, right? Because there's a huge attrition, especially in squamous cell cancer, that probably, depending on the center, as low as 50% of patients even get to second line. So I think you need to use all your cannons up front. Okay, are there any situations in which you prioritize Nivo chemo, Pembro chemo, or Tisli chemo over the others in patients with Claudin-negative, HER2-negative metastatic gastroesophageal cancer? And both Dr. Shah and Dr. Van Cutsem say there are situations. Can you please maybe take turns and briefly tell us? Eric, maybe you can start.
So sorry, I forgot the question. Are there any situations?
Do you use certain immunotherapies over others?
The other?
Economic factors do play a role. That's the main reason why I answered yes. If one checkpoint, so that's a situation where you may prioritize one over the other. If one is cheaper than the other, I may. That's the main reason. But not efficacy-wise, I don't think we can conclude.
What about you, Manish?
Yeah, so it's a little bit of convenience or maybe concern for toxicity. Nivolumab is given every other week, and if you're worried about toxicity and you want to monitor the patient closely, then you might lean toward that. Alternatively, you could give pembrolizumab once every 6 weeks. And so if you're worried that the patient may not be as compliant, then you could just at least give it, and then hopefully they come back and you can give it again.
All right. And of course, the rate of toxicity may be higher at higher doses.
Yes.
So that's always an issue. Are there any circumstances in which you would still offer an anti-PD-1 antibody regimen to the patient with newly diagnosed PD-L1 negative gastroesophageal cancer? And I said for Claudin negative, again, because if they're Claudin negative, giving FOLFOX, I just can't bring myself to do it by itself. So I think others say if MSI high, realizing most patients are PD-L1 positive, that's a good answer. Sam said the same. So maybe Manish, any last thoughts about it?
No. I think we discussed it. I think that tissue heterogeneity aside, I think the MSI high answer is probably the correct one. Here I did drink the sauce from UCLA, so.
Okay. All right. Well, what a great discussion. Thank you, and such a pleasure to moderate and an honor. So thank you all, and feel free to chat with the faculty after. We're here for you, and great.
Thank you
very much.